Hi everyone, welcome to our Prescribing and Surgery series. Today's our fourth session, which will be on prescribing in pre-op. And my name's Dr. Aisha Musa. I'm one of the co-leads for prescribing in surgery. So just a disclaimer, the Prescribing and Surgery series has been created by junior doctors, and so it's entirely on a voluntary basis. And all the content is accurate to the best of our knowledge, and neither the tutors nor mine take responsibility for any unintentional inaccuracies. So as you can see, today's session will be on prescribing in pre-op, and our next week's session by Dr. Jemmett will be on diabetes medications. So going straight away into case one. So case one, a 78-year-old male is seen in the preoperative clinic 2 weeks before his elective knee replacement for severe osteoarthritis in his left knee. Past medical history, he's got atrial fibrillation, he's had a stroke 1 year ago, he's got osteoarthritis. In terms of his medications, he takes warfarin, bisoprolol, and he has no known drug allergies. And his weight is 84 kg. So the question is, preoperatively, how will you manage his warfarin prescription? So will you continue his warfarin? Will you stop his warfarin 2 weeks before surgery? Will you stop it 5 days before surgery? Will you stop it 5 days before surgery and prescribe treatment dose low molecular weight heparin? Or will you avoid surgery as he's a very high risk for thrombosis? So I'll just release the first poll into the chat. Okay. So far, everyone's going for D. Any more responses? Okay, B as well. Okay, I'll give you a few more seconds. Okay, fine. So more people are going for D than B. So D is correct. And I'll explain the thought process now. So if you go on BNF NICE, if you go on the preoperative anticoagulation section, it says warfarin should be stopped 5 days before elective surgery. Patients stopping warfarin prior to surgery who are considered to be at high risk. So, for example, they've had atrial fibrillation with a previous stroke or a TIA, may require interim therapy known as bridging with a low molecular weight heparin using treatment dose. So this is just using some information from the Maidstone and Tunbridge Wells. So as you can see in the top half where you assess thrombosis risk, this patient will be high risk because he has AF with previous stroke / TIA. And if you follow this algorithm through, it says that if patients are high risk, you would stop warfarin 5 days before surgery to allow their INR to normalize, and you would start them on treatment dose low molecular weight heparin. So in this trust, they would start them on dolteparin, and then it has a few more kind of information where it says, take INR 1 day prior, and if INR is higher, then discuss with the consultant. So, of course, this information will be trust specific. So always do kind of follow the guidelines in your trust. So BNF says that low molecular weight heparin should be stopped at least 24 hours before surgery. And yes, so in clinical practice, use your local trust guidelines, and in your PSA exam, make sure to use the BNF. And this is just the table that the trust gives you on how to dose the dolteparin treatment dose for heparin bridge. So as you can see, this patient's weight was 84 kg, so that's above 83. So if his creatinine clearance is more than 30, you would give him 18,000 units once daily. And if his creatinine clearance is less than 30, you would give him 12,500 units once daily. And you would also have to consider dosing in patients with renal failure as well. And in terms of in the post-operative management, so you would restart the low molecular weight heparin 6 to 8 hours post-operatively if hemostasis is secure, and you would recommence the usual warfarin dose on the evening of surgery if there's no excessive bleeding, or you continue the dotapurin or unfractionated weight heparin until target INR has been reached. So if you check so in this case, this patient is undergoing orthopedic surgery, so that's a high bleeding risk. The BNF says if surgery carries high risk of bleeding, low molecular weight heparin should not be restarted until at least 48 hours after surgery. BNF says if hemostasis is adequate, warfarin can be resumed at the normal maintenance dose on the evening of the surgery or the next day. Local guidelines may differ, so of course use your local trust guidelines in clinical practice, and of course use the BNF in your PSA exam. So now if we move on to the next case, so case 2, a 65-year-old male presents with urinary frequency, hesitancy, straining, weak flow, and has noticed blood in his urine. Past medical history, he's got VTE 1 year ago secondary to malignancy. He's undergone a TURBT for his bladder cancer, so that's a transurethral resection of the bladder tumour. In terms of his medication history, he takes apixaban, he's got no known drug allergies, and his creatinine clearance is 60. So when you do a DRE, you note a hard mass on palpation of the prostate, and his PSA is more than 3. A multi-parametric MRI prostate scan is conducted, and prostate biopsy is advised. He's scheduled for a prostate biopsy in 2 days to investigate for bladder cancer. So question, prior to his prostate biopsy, how will you manage his apixaban prescription? I'll put the voltage up. And I'll give you a few minutes to answer that question. Okay, so 50% of people going for hold apixaban 24 hours before, and 33% going for hold apixaban 48 hours before, and some going for 72 hours before. Okay, so the correct answer is to hold apixaban 24 hours before. And this is just to quickly show you guys how we calculate creatinine clearance. So this is using MD Calc. So when you calculate the creatinine clearance, you need to take into account their gender, age, weight, and their creatinine result. Just a note, if your trust has an online gentamicin calculator, for example, which works out your creatinine clearance as part of it, do use your trust guidelines your trust calculator instead of the MD Calc, because sometimes there may be variation in the MD Calc. So again, using Maidstone and Tunbridge-Wells guidelines. So in this case, this patient has moderate risk of thrombosis because they have VTE provoked by malignancy, and they have a standard risk of bleeding because they're awaiting a prostate biopsy. So in terms of the preoperative management, because the creatinine clearance is between 50 to 80 and they're on apixaban, and they've got a standard risk, you would hold the apixaban for 24 hours preoperatively, and post-operatively, you would resume it 24 hours post-operatively at the normal dose. So in terms of the BNF guidelines, so if you go under the surgery and long-term medication section of the BNF, it says that anaesthetists and surgeons should assess the relative risks and decide jointly whether the antiplatelet or the anticoagulant drug should be stopped. Okay, so a lot of people got the answer right for that question. So next case. So case 3. A 29-year-old female presents to preoperative clinic 1 week before her elective C-section. She is 37 weeks pregnant with twins. Her past medical history, she is diagnosed with myasthenia gravis. Medication history, she takes prednisolone 60 milligrams as her daily maintenance dose, and she's been taking it for 4 months, and she's got no known drug allergies. So in terms of the question, what would you prescribe during her C-section at induction? So I'll give you a few minutes to answer this question. A few seconds, sorry. Okay, so most of the people going for methylprednisolone, with a third of people going for hydrocortisone 50 milligrams IV. Okay, so the correct answer is E, hydrocortisone 50 milligrams IV. So if we look at the hydrocortisone section of the BNF, it says that if a patient has corticosteroid replacement, more than 10 milligrams of prednisone daily or equivalent within 3 months of moderate or major surgery, then at induction of surgery, you should give 25 to 50 milligrams of IV hydrocortisone, and this is following their usual oral corticosteroid dose on the morning of surgery. Okay, hope that makes sense. So we're going to go straight on to case 4. So case 4, a 48-year-old man is undergoing a minor procedure, skin abscess drainage, tomorrow morning. Past medical history, he's got type 2 diabetes. In terms of medication history, he's on metformin, 500 milligrams twice daily, Humulin I, 10 units once daily in the evening, and he's got no known drug allergies. His HbA1c is 60 and his eGFR is 70. So prior to his minor procedure tomorrow morning, how should we manage his Humulin I prescription? Just going to start the poll. Okay, so most people are going for no dose adjustment needed, with around 14% going for omit it the day before and reduce the dose by 20% on the day before as well. So the answer is actually A, so the day before reduce the dose by 20%. So if we go on the NICE guidelines on use of insulin during surgery, it says that patients are undergoing elective surgery, minor procedure with good glycemic control. So in this case, his HbA1c is less than 69. On the day before the patient's usually insulin dose should be given as normal. However, once daily long-acting insulin should be given at a dose reduced by 20%. Okay, and this is just the Centre of Perioperative Care, which shows that in the case of once daily long-acting insulin being given in the morning, you would give 80% of the dose. Wouldn't they use LA for IND of an abscess? Local anaesthetic. They could use local anaesthetic, but it does depend on the size of the abscess. So if it's a really large abscess, you might require kind of general, potentially. Okay, so case 5. Sorry, I hope that answers that question. So case 5, a 57-year-old man is scheduled for an outpatient coronary angiogram tomorrow to diagnose coronary heart disease. Past medical history, type 2 diabetes, medication history, metformin 500 milligrams BD, allergies, he takes penicillin, and his eGFR is 55. So prior to his coronary angiogram tomorrow, how should we manage his metformin prescription? Okay, so 50% of people are going for omit metformin on the day of the procedure but continue it the next day. 16% going for omit metformin on the day of the procedure and for the following 48 hours, and 33% for continue metformin twice daily. Okay, so some variation. So the answer is D, omit metformin on the day of the procedure and for the following 48 hours. So if you look at the NICE guidelines, it says that metformin is renally excreted, renal impairment can cause accumulation and lactic acidosis during surgery. And they said if contrast medium is to be used, or if the eGFR is less than 60. So in this case, the eGFR was 55. Then metformin should be omitted on the day of the procedure and for the following 48 hours. Okay, so we move on to case 6. So a 60-year-old male is scheduled for a hip replacement today for his severe right hip osteoarthritis. Past medical history, he's got type 2 diabetes, he's got osteoarthritis, medication history, takes metformin 500 milligrams BD, Lantus 10 units once daily in the morning. He started on standard rate, variable rate insulin. His Lantus is reduced to 8 units, so it's reduced by 20%. Metformin is held whilst on variable rate insulin. His capillary blood glucose is measured hourly, and the nurse informs you that his CBG is now 2. Considering his CBG is 2, how should we manage his variable rate insulin prescription? So I'm going to start the poll. So we've got 4 responses so far. 5. Okay, fine. So it seems like everyone's going for stop variable rate insulin and give 20% glucose 100 milliliters IV, which is the correct answer. You would give 20% glucose 100 milliliters or 10% glucose 200 milliliters to treat the hypoglycemia. So quickly, just to show you guys that in the case of metformin, when a patient is on variable rate insulin, you would hold the metformin and you would only commence it when the variable rate insulin is down and the patient started to eat and drink normally. Okay, so quite a bit of information here, but we'll go through it slowly and we'll go through it using trust guidelines, which will hopefully explain it a bit more. So this is the NICE guidelines on variable rate insulin. So it says that if a patient has a major procedure, so basically a surgery requiring a long fasting period of more than one missed meal, or if their diabetes is poorly controlled, they will require a variable rate insulin infusion, which will be continued until the patient is eating and drinking and stabilized on their previous glucose-lowering medication. So on the day before surgery, you would give the once daily long-acting insulin at 80% of the usual dose. And on the day of the surgery and throughout the intraoperative period, you would give long-acting insulin analog, again at the 8% of the usual dose. On the day of surgery, you would start an intravenous substrate infusion, which would contain potassium chloride with glucose and sodium chloride. And that's to help replace their electrolytes whilst they're on the variable rate insulin. So the variable rate insulin infusion is made up of soluble human insulin, which will be in sodium chloride 0.9% infusion. And again, you would co-prescribe IV glucose 20%, and that's in case of hypoglycemia. So this is using trust information on variable rate insulin from Doncaster and Bassett Law. And essentially what you can see in the red that I've circled is that if the capillary blood glucose goes below 4, you would stop the variable rate insulin and you would administer 100 milliliters IV 20% glucose or 200 milliliters IV 10% glucose. And you would only restart the variable rate insulin once the capillary blood glucose is above 4. So if you go to the bottom, you can see that there's different rates of insulin. So standard rate is for most patients, reduced rate is if they're insulin sensitive, and increased rate is for patients that might require more insulin, for example, if they're on steroids. And if you see on the top right, you can see that the soluble insulin, the human insulin, is the human actrapid, and that would be 50 units made up to 50 milliliters with sodium chloride 0.9%. And then if you see below that, which I've circled, so that's the IV substrate fluid prescription, which you would co-prescribe to supply the patient with the electrolytes whilst they're on the variable rate insulin. So in this trust, the first line is 5% dextrose with 20% or 40% of KCl. But what you need to know is that the fluid substrate that you would prescribe would depend on the trust that you're at. So it depends from trust to trust based on availability. So in clinical practice, make sure to follow your local trust. And yes, so on the top it says prescription of IV management of hypoglycemia. So again, the 20% of 100 milliliters IV glucose or the 10% of 200 milliliters of IV glucose. And if you see where I've underlined, so yeah, just make sure to check potassium levels when you're co-prescribing the patient with substrate fluids. They may require 20 millimoles of potassium or 40 millimoles of potassium, depending on their potassium levels. And if you see at the bottom, in terms of exit criteria, so we stop variable rate insulin when the patient is able to eat and drink without nausea or vomiting, and when they're able to restart their normal anti-diabetic medications. So I hope that makes sense. So on to case 7. So case 7, a 63-year-old female is scheduled for an elective hemorrhoidectomy tomorrow morning Past medical history, she's got type 2 diabetes. Medication history, she's on metformin 500 milligrams BD, pioglitazone 30 milligram once daily. Allergies, she has no known drug allergies, and her eGFR is 80. So how would you manage her pioglitazone prescription preoperatively? Okay, so we've got 6 responses so far, with 50% of people going for omit on the morning of surgery. So omit in the morning of surgery and the following 24 hours after. Equal amount of people going for continue as normal, and some going for omit on the day before surgery. So the correct answer is A, continue as normal. So if we just have a look at the guidelines, so on the left you've got guidelines from the BNF, which says pioglitazone can be taken as normal during the whole perioperative period. And on the right, we've got guidelines from the Centre for Perioperative Care, which says pioglitazone can be taken as normal the day before admission, and also for patients that are having AM surgery, patients having PM surgery. Essentially, for the entire perioperative period, you can continue your pioglitazone as normal. Okay, so this brings us on to case 8. So case 8, a 34-year-old female is seen in the preoperative clinic. She's scheduled for an elective inguinal hernia repair in 6 weeks. Past medical history, she's got a diagnosis with eczema. Medication history, she takes this combined oral contraceptive pill, and she has no known drug allergies. So the question is, prior to her elective hernia repair, how will you manage her combined oral contraceptive prescription? And this is our last question. Okay, so most people going for stop combined oral contraceptive 4 weeks prior to surgery and provide alternative contraceptive, with some going for stop COCP 2 weeks prior to surgery. So the correct answer is to stop combined oral contraceptives 4 weeks prior to surgery and provide alternative contraceptive. So this is the nice guidelines. So it says that the combined hormonal contraceptive use should be discontinued at least 4 weeks prior to major elective surgery, any surgery to the legs or pelvis, or surgery that involve prolonged immobilization of a lower limb. An alternative method of contraception should be used to prevent unintentional pregnancy, and that the combined hormonal contraceptive may be recommenced 2 weeks after full remobilisation. It also states that in accordance with the UK medical eligibility criteria for contraceptive use, you can use progesterone-only pills, injections, implants, and intrauterine systems as contraceptives in females undergoing surgery. So these are all types of contraceptives you can give to the patient instead of the combined oral contraceptive pill whilst you're holding it for surgery. I hope that makes sense. So just in terms of your clinical practice and also to help in your PSA preparation, the BNF has a section on surgery and long-term medication, and this kind of contains their guidance on medications that you have to continue even if the patient is having surgery, or medications that you need to hold, and some medications that it depends, and you can kind of discuss it with seniors in clinical practice as well if you're ever unsure. Okay, and these are the references that I used. And this is just a feedback form for today's session. I'm just going to release it into the chat. And this is just to help inform kind of future sessions on things that went well, things that can be improved. I hope that helps. I hope that today's session was useful. Okay, thank you. Was there any questions? Okay then, thank you very much. Our next session will be next week on diabetes medication. So we mentioned some diabetes medications in terms of kind of prescription during surgery, but next week Dr. Jemmett will discuss diabetes medication in a lot more depth. So thank you very much for coming to today's session. I hope it was useful. Thank you.